So I am Isabelle Conepo. I am a pediatric rheumatologist, and I am the head of the referral center for auto-inflammatory disease and inflammatory amyloidosis at Kremlin-Bicêtre Hospital. And now I am going to tell you about how to manage treatment of Kawasaki disease. So treatment of Kawasaki disease is not a very easy issue. And the main objectives are, of course, to abate the inflammation, but also to avoid coronary lesions in different clinical settings, common Kawasaki disease, patients with high risk of resistance to IVIG and coronary dilation, and also to take care of patients who are resistant to IVIG. So the standard treatment is represented by intravenous immunoglobulins with aspirin. So intravenous immunoglobulin are the first-line treatment. It is recommended by the American Heart Association, by the European recommendation shared in 2018, but also by our French recommendation in 2022. So IVIG must be given at the dose of 2 grams per kilo over a period of 10 to 12 hours. Ideally, the infusion may be done 10 days following the start of the illness and even before 7 days of fevers. You can give IVIG after the 10th day of illness if there is persistent fever without another explanation, or if there are coronary anomalies with inflammatory syndrome, with high CRP. And of course, this treatment is not a scoop because everybody knows that this is still the recommended first-line treatment. Most new is the role and the necessity for aspirin in the initial treatment of Kawasaki disease. For many years, we have used aspirin in association with IVIG, and we used it at high doses from 80 to 100 milligrams per kilo, with a number of difficulties regarding tolerance and hepatic toxicity. Then with time, the dose have been reduced, but there is still no consensus for a dose of aspirin we should use at the initial phase of treatment. There have been some studies that have tried to evaluate high-dose aspirin, low-dose aspirin, and even no aspirin at all. And the conclusion of the studies show no real differences regarding the outcome of the coronary aneurysms. The only thing that can be kept in mind is that when we use high dose of aspirin, we may have more rapid decrease of fever. But there is no influence on the length of hospitalization and also in the development of coronary aneurysms. So in the absence of a randomized controlled study of aspirin versus no aspirin in addition to IVIG, the recommendation vary between continents, I could say. And then in the US, it is still recommended to use ASA in addition to IVIG, that 8 to 100 milligrams per kilo. In Europe, it's 30 to 50 milligrams per kilo, and also in Japan. And in our French recommendation, we have given the possibility of using aspirin at antiaggregant dose since the beginning of the disease, in addition to IVIG if there is no further complications. So during the acute phase, though the first treatment is an infusion of polyvalent immunoglobulins at 2 grams per kilo in one go, plus aspirin at an anti-inflammatory dose, or in France, we can use anti-aggregant dose since the beginning. In most cases, the abatement of fever is very rapid, in 80% of cases, and the CRP normalized between 7 to 15 days after the beginning of the disease. And it has also benefits in reducing the risk of aneurysms from 25% to 5%. If we have at the beginning the anti-inflammatory dose, we can consider anti-aggregant dose until day 45 if all cardiac echoes are normal. So this is something important. In general, the tolerance of the IVIG is good, but we have to be careful that the infusion may not be too rapid at the beginning. There are some secondary effects like headaches, meningismus or allergic reactions, or proteinuria, which is in general related to the osmotic charge of IVIG, so it is usually transient, but it needs to be monitored. And there have been some cases of hemolysis with some specialties of IVIG, but it is rare. So if the patient do not respond to IVIG, it is really a problem, and it changes the prognosis of Kawasaki disease, because those patients have an increased risk of coronary lesions. There are some categories of patients who are really importantly at risk. Those very young patients below the age of 1 year, but also we have, in some cases, patients who have Kawasaki disease before the age of 3 months. The diagnosis is so difficult, and they have, in general, large and multiple aneurysms. And we had the surprise to see that in Western countries, we have an unexpected high number of patients with coronary aneurysm, and it's more than 25%. And also, there is an important clinical heterogeneity, and so it's complicated. Some presentations are atypical, very digestive, and misleading. And also, some patients may start with Kawasaki disease, but may have a finally systemic GIA or mevalonate kinase deficiency, or a phenotype which is really look like periarteritis nodosa with multiple involvements. So when do we start IVIG? So as soon as possible for all patients who have the American Heart Association criteria for complete or incomplete Kawasaki disease. And of course, for all the patients who have all the criteria, we can really start IVIG before 5 days of fevers. And there is here a window of opportunity because they have a lot of inflammation in these cases, and then it is important to treat them very early. In some cases, we have only a suspected Kawasaki disease. It's not very easy, but in these cases, we may have children who have fever during 5 days and more, and they have only 2 or 3 compatible clinical criteria. So, or you may have infants with fever for at least 7 days without another explanation. And in these cases, to assess biological inflammation is very important. If there is no biological inflammation, so you can only continue the follow-up of your patient and make re-evaluation regularly, clinical and also echo. And if you don't have more signs, so it's not necessary to treat the patients. In the other cases, if you have inflammation, or if you have abnormalities like anemia or thrombocytosis of hypoalbuminemia, so you need really to treat your patients, and also if you have a positive echocardiogram. So there are limitations of the treatment with IVIG. So I said that 20% of the patients may not respond to standard treatment. And also we have different profiles of evolution. So there have been a very interesting study there that tried to show the different cardiac evolution regarding the age of the patient, and the patient were stratified in a category of patients less than 1 year and patients with more than 1 year. And you can see that the maximal Z-score is the most important at the initial phase of the disease, but you can see that some patients at 1 week develop also an important lesions in their coronaries, and up to 5 weeks they still may have important dilations of their coronaries. If we look at the age at treatment, you can see that when the patients are very young, you have the highest mean Z-scores. And also, of course, the delay to treatment is something very important to consider. So if you treat early your patients, you may have less high Z-score than if you treat them very late at 10 or 11 days. And also the level of inflammation is important. So if you have very high level of inflammation, here it is a level of albumin that is represented. You can see that really you have higher risk to have high Z-scores. So what can you do after this? So we need really to stratify the risk for our patients. So there are scoring systems that have been developed for predicting IVIG resistance in Kawasaki disease. So most of them have been developed in Japan for Japanese, but we still use the Kobayashi score, and you can see that this score takes into account the level of the natremia, the number of days of illness, also the ALAT, the platelets, the level of CRP, the age, and the percentage of neutrophils. And then the Kobayashi score is positive if we have at least 5 points. So we have tried to test these scores in our populations, and you can see that in Japanese population, the sensitivity of the Kobayashi score is high, 86%, and the specificity is 67%. In non-Japanese patients, you can see that the sensitivity is low, but the specificity is even higher. So it's still useful to use a Kobayashi score in our patients, and if they are negative, we cannot say anything, but if they have a positive Kobayashi score, and whatever they are Japanese or non-Japanese, this is important to consider that they have a high risk of developing IVIG resistance. So this is the score that we have developed with Mariam Piram in our French cohort Kawanet, and you can see that our predictors for unresponsiveness to IVIG were the ALAT level at 30 or more, hepatomegaly, lymphopenia at 2,500 or less, and also the time to treatment less than 5 days. And then this score was really sensitive, 77%, and the specificity was 60%. So we want also to point out that some laboratory values are important in assessing risk stratification for IVIG resistance, like low sodium, raised bilirubin, raised ALAT, low platelet count, high CRP, and low albumin. So we are really to make a reasoning taking into account all these parameters. So what could be the pragmatic approach? And so we could really stick to the British recommendations though they consider a patient IVIG resistant if he has ongoing fever and or persistent inflammation and or persistent signs of Kawasaki disease 48 hours or more after receiving IVIG as a single dose of 2 grams per kilo. So patients with features of the most severe disease and therefore the greatest likelihood of developing coronary aneurysms are the very young, so less than 1 year old, those who have persistent elevated CRP despite IVIG, liver dysfunction, hypoalbuminemia, and anemia. Those who develop features of macrophage activating syndrome or shock, those who have evolving coronary aneurysm, and those with ongoing inflammation at presentation or dilation when compared with age-related normal range and or extracoronary manifestation, including mitral regurgitation and pericardial effusion. So regarding this, we ask ourselves whether we should do more than giving IVIG on first line to reduce the risk of coronary aneurysms. So there have been a number of studies that have evaluated the interest of corticosteroid as first line for treatment for reducing the coronary risk. And then you can see that there have been at least 16 studies. They have included a number of patients. And then some of them have been comparative, and they have compared corticosteroid plus IVIG as initial therapy versus initial IVIG alone, with a duration of finish which was variable, but with a median of 5.7 days. And in these studies, it favors the use of corticosteroid, even if you see the p-values, only few of these studies had significant results. And for the second category of studies, it was the use of corticosteroid in patients who were predicted at baseline to have a high risk of IVIG resistance, so essentially a patient from Japan. And then you can see also here that it seems to favor the corticosteroids, even only 2 of the studies gave really significant results. So there are some remaining questions because we have also to point out that only 4 on 16 studies included patients who have coronary aneurysm at the baseline, and also the time for initiation of corticosteroids was variable, 6 to 9 days of fevers. There were also no effects of corticosteroid on coronary aneurysm in some studies, and but we could consider that the main merit of corticosteroid therapy is the early suppression of vessel inflammation before vascular remodeling. Then it is possible that any delay in initiation of treatment probably increases the risk of coronary aneurysm. So several questions remain unanswered regarding the use of corticosteroids. So you can see the number of studies that have been done. And the problem is that the type of steroid, their duration were quite heterogeneous, though they use prednisone orally or methylprednisolone at high dose or dexamethasone. So it is very complicated to have really a good interpretation and good comparison between these studies. Though our question is for whom? Is it applicable in the Caucasian population? And we don't have the response yet. And finally, which type of corticosteroid we should use and the duration, etc., etc. So there is one thing that really we are certain that there is no efficacy of steroids in a second line, and there have been some studies who have demonstrated very well. And then the most important thing really to avoid coronary dilation is probably to use the window of opportunity and to treat the patient the earliest as possible. So what are our recommendations in France? So we really suggest to evaluate the risk for resistance to IVIG. So if we have a patient without risk, so we use IVIG at 2 grams per kilo. And before 10 days of fever, and we use aspirin at a moderate dose or at low dose if there is no complication. So for those patients who have high risk, those who have an age before 1 year, who have shock, who have major inflammation, who have macrophage activity syndrome, who have early coronary dilation of aneurysms, we recommend to use corticosteroids, but we suggest either methylprednisolone at 0.10 milligram per kilo every 12 hours or methylprednisolone at 10 to 30 milligram per kilo. So we have not a fixed scheme for this, and really we have no evidence, but it is a precaution principle, I think. So you can have a look here at the American Heart Association recommendations. They really stick to hers. And so they use IVIG at the dose of 2 grams per kilo. And they use the Kobayashi criteria, even in the non-Japanese criteria, to stratify the risk of IVIG resistance. They use aspirin at 30 to 50 milligram per kilo per day, and after they reduce to antiaggregant when the CRP levels are falling. And if the patient develop aneurysms, aspirin must be continued at low dose on the long term. So for the second-line treatments, we have no solid evidence. So the first recommendation was to perform a second IVIG at 2 grams per kilo, but we have no controlled trial and the experience is essentially retrospective. We have 3 studies using infliximab, and one was a comparative trial using infliximab at first line versus IVIG plus infliximab. And in this study, it was shown that the fever and the CRP and hospitalization were diminished earlier in those patients who receive infliximab in addition to IVIG. But unfortunately, the study was unpowered to demonstrate any efficacy on coronary aneurysms. So there have been also 1 study using cyclosporin in patients who were selected with the Kobayashi criteria to be resistant KD, and then they were randomized to receive either IVIG or IVIG plus cyclosporin, and in those patients receiving IVIG plus cyclosporin, they developed 40% of aneurysm versus 31% in those patients receiving IVIG alone. Though there are other options with anakinra, because IL-1 is an important cytokine in Kawasaki disease and plays an important role in the development of coronary aneurysms. So there have been 2 trials, the ANAKID phase 1-2 trial and the Kawakina trial, which is a phase 2-1 trial. And, but they are not comparative. And in very severe cases, and especially when you have multiple locations of vasculitis, you can use cyclophosphamide or also plasma exchanges using albumin. But also in this case, we have no evidence. So in these cases, it's very useful to discuss with the reference centers to make a decision, because it is really difficult cases with patients who are really have very high risk of severe complications. So this is just to show you the Kawasaki studies, which was a phase 2 trial, which was conducted in patients who failed to respond to IVIG. They may have received either one IVIG or more, and you can see that they received anakinra at a starting dose of 2 milligrams per kilo, and it was possible to increase the dose up to 8 milligrams per kilo. So there was a response in fever, but it was relatively slow within 2 to 3 days. The CRP also decreased very well, and in most patients the CRP was less 10 milligrams per kilos at day 15. The most interesting findings were on the coronaries, because you can see that at the screening period 90% of the patients had coronary dilations, and you can see that at day 14 and day 45 only 40% of the patients had still coronary dilation, and of importance, they did not increase. So it showed that there was probably an interesting effect of anakinra on coronary dilation, and for sure it's really necessary to go further exploring the role of anakinra in the treatment of Kawasaki disease. So how often should we perform an echocardiogram? So in those patients without complications, it's necessary to have 3 echo during the 6 first weeks of the disease, and ideally they should be done every 2 weeks. So in those patients who are uncomplicated, so it's not necessary to do a cardiologic follow-up after 6 weeks. In those patients who have significant high Z scores and progressive coronary abnormalities, so they need to have echocardio twice a week until the luminal dimension have stopped increasing. And in those patients with aneurysm development at high risk of coronary thrombosis, so they need at least twice a week an echocardio, and if possible in a cardiology department. And this follow-up needs to be pursued until the dimension until 45 days of illness, and after 45 days of illness, it can be pursued once a month until 3 months after the onset of the disease. So this is our decision tree. So after the first line treatment, so in those patients who are not complicated, they have aspirin for a maximum of 8 weeks. After they have a follow-up consult at 3 months, and if everything is okay, they can stop aspirin and we can close the file. If those patients have coronary involvement, they need to maintain aspirin at low dose at least 1 year, plus anticoagulant if they have coronary dilation more than 6 millimeters. After, at 1 year, we do a core scanner, and if they have coronary dilation and or aneurysm, which are limited, less than 6 millimeters. If they have an aneurysm with coronary dilation more than 6 millimeters, they need to have an angiography. If the coronary are normal, so we can stop aspirin and close the file. If they have a persistence of coronary abnormalities, if it's limited with a dilation less than 6 millimeters, so they need to continue aspirin and to have a consult once a year. If there are still important dilation of 6 millimeters or more, they need to continue aspirin and anticoagulant for life and to have a follow-up every 6 months. So I really thank you for your attention. And then I would like to acknowledge there three persons, I have to say. First, Tomisaku Kawasaki, and also Mariam Piram, and also Rolando Simage, who is really a friend and a great expert of Kawasaki disease, and who left us some year ago. So thank you for your attention.